Welcome everyone. My name's Marika. I'm part of the alumni team here at King's. Thank you so much to everyone joining us here today for the first of our new online events and programming for alumni. As you can see, we're having a few growing pains here, but hopefully we'll get that figured out. Before I start, let me just point out that if you want to post about this webinar on social media, please use #ForeverKings. Today, we're very excited to be sharing the latest on a pioneering new app, the COVID-19 Symptom Tracker, which has been developed by researchers at King's in partnership with health data science company Zoe, and launched only a couple of weeks ago. Some of you may already be using the app. We are very excited to be joined today by Professor Tim Spector, Head of the Department of Twin Research and Genetic Epidemiology at King's College London, and founder of Twins UK, the biggest twin registry in the UK. We are also very pleased to have with us Dr. Claire Steeves, Clinical Senior Researcher at King's College and Clinical Deputy Director for Twins UK. Both Claire and Tim have been working extremely hard these past few weeks. You may have seen them on the news. They've been working closely on the development and rollout of this app, and they're going to explain to us how it works, who can use it, how the data gathered will hopefully help researchers to better understand and begin to slow the spread of this pandemic. Don't worry if you haven't downloaded the app yet, you can still do so, and we'll share the link after the webinar. Just a bit about the format of the webinar. So my colleague Francine from the alumni team is going to ask a few questions of our panelists. Throughout the webinar, you'll be able to use the Q&A feature of Zoom to submit your questions to the panelists. So you can find the Q&A button on the little bar at the bottom of your screen. When you open it, you'll be able to submit questions as well as see everyone else's questions. So if you don't want to submit a question, you can also help us by liking other people's questions. And at the end of the discussion, we'll then select the most asked questions to be posed to our panelists. Francine, if you're ready, I'm now going to hand over so that you can chair the rest of this webinar and begin with the interview.
Thank you, Marika. And again, apologies for all the people who can't attend this webinar at the moment, but we're looking into it right now. Thank you very much, Tim and Claire, for joining us today. It's a pleasure to get to know more about this pioneer app. And before we start, can you tell us what exactly is a symptom tracking app and if other symptom tracking app already exists?
This, we've been going 2 weeks, and certainly when two weeks ago when it launched, we were unaware of any other symptom tracking apps in the UK. We had heard of some a few days earlier launching in Israel, and these are different to other apps which do exist, which have been used in places like Singapore, which were contact tracing apps, which are slightly different. They're more about an app which will geospatially follow someone who's had a positive COVID test and see who's been in contact with them in a time, and use that to isolate those other individuals. That sort of app works well at the beginning of an outbreak and doesn't work so well when basically it's everywhere. And so that was the basis of why we wanted to get this app started quickly, and we wanted to not just have a yes/no, do you have the disease, but actually work out much more about the disease itself, because as all of you probably know, in the news, all you're hearing about is the number of intensive care beds, number of confirmed cases based on a few limited tests, and the number of, sadly, of deaths. And that doesn't really illustrate what's going on with an infection like this. So the very first bit of exciting news we had was what that amazing range of symptoms were out there. And so that's what we wanted to capture in the app, not just fever and persistent cough, but let's give people a chance to note down what they were suffering and when they were suffering it and when they got better. So we get a real better picture of exactly what this strange virus is doing to people and why some people seem to be asymptomatic, others get mild disease, and others extremely severe disease. And only by getting that big picture rather than just at the end stage can we get grips on this. And I think it struck a chord with the general public. People were fed up with not being able to get through to 111. Their GP wasn't interested in their minor symptoms. And so we were like this giant therapy for people. They could click onto our app, tell us about their symptoms, and believe that someone was actually interested in their results. And I think that's why within 24 hours, 1 million people like yourselves had downloaded the app and spread that word onto other people. And so and now we're over 2.1 million people have downloaded it, and about a third of people are still using it every single day to give us real life feeds about what's happening all over the country.
So what's really key as well is that what Tim's describing is that what we know from national data is just the very tip of the iceberg of COVID experience. And of course, people are mostly suffering at home with this virus, but nobody was collecting any data on what they were experiencing or how they were, what kind of problems were they having. And that's a problem, because if we only understand the tip of the iceberg, we don't understand what could be positivity spreading within the community. So using this app, we've identified some new symptom clusters which appeared to have been ignored, which actually might well indicate disease. I don't know if you want to talk about that now, Tim.
Yes, so we've got, oops, can you hear me all right?
Yeah.
So we had this whole range of symptoms, and I've got, I think I can see them.
I can show you here.
Okay. Yeah, so the symptoms we collected ranged from shortness of breath, abdominal pain, confusion, chest pain, hoarse voice, persistent cough, diarrhea and fatigue, and lack of appetite, as well as fever. And what we did is we used a proportion of the roughly 1.5 million people who had a COVID test. So these are often healthcare workers or people who've been to hospital. And in that small proportion, worked out which of these symptoms best matched having a positive test as a way of training this data set. And we found that they all contributed to somewhat to it, but the one that stood out above all was this loss of smell and taste, and the two go together. And it's obviously an unusual symptom. It doesn't really go with many other common ailments, and so that was our first novel finding from this data. We suddenly realized, hey, we've hit a gold mine here. Not only a lot of people replying, but this data is incredibly valuable because we're finding out new things about the disease and new ways of classifying it and seeing who is likely to be infectious. And there are some people who just get this symptom and nothing else. Others get it in variety with the other ones. All combinations seem to be possible. And that's really what was our first major finding. Claire and her team have been writing a paper on this, which we've submitted in preprint form. And we think based on this, the government should change their views and have some of these alternative symptoms, particularly loss of smell and taste, as an indicator that somebody's been infected.
Okay. Claire, did you want to add something to this?
I suppose the other things that we're looking at, so there's a number of things that we're looking at now with the app. One of the things is are the factors which we've seen in China and other countries to be predictive of COVID infection and in severity of infection, are they actually the same in the UK population? And interestingly, there's actually very few studies out from Europe so far on this. So we'll be looking very carefully at that, looking carefully at other risk factors like obesity and smoking. And certainly we see a fairly clear signal in smoking, and we've already sort of given a blog about that, which you can find on our website, which is covid.joinzoe.com, and there's blogs on there to look at. So what are the risk factors, and then what is the development of the disease? And the reason why this is so key is because clinicians like myself looking after people with COVID, but also people in intensive care units, are finding that people might be suffering with the disease and managing for a while, but then suddenly decompensate and things change, and then they need ventilatory support or certainly hospitalization. And so if we can really work out what are the symptom clusters that can predict that, that would be really helpful in terms of targeting help to those who really need it and potentially preventing problems. So I guess that's one of the other sort of scientific ideas. And then Tim, do you want to talk about the maps? Because one of the other things we can do, because this is a national data set, is because we are asking people to tell us their postcodes. Obviously, we're not sharing those postcodes. We're just looking at we were only able to see the very first part of the postcode, but nevertheless, with that data, we can see a map of how COVID symptoms are mapping across the country and how they're mapping in cities in particular and across different regions that have different risk factors. So I don't know if, Tim, you want to maybe show some of the maps or...
Yes, if you get them up on the screen, I'll take people through it. So all these maps are being updated at the moment every other day, but we hope to do this daily. And anyone can go on to the covid.joinzoe.com website, and you may want to do that now, or I can probably share my screen. You can see that now. And you can see this is the interactive map of the UK. This is from a few days ago, and you can blow it up into these regions, and you can look on somewhere here, and the Isle of Anglesey, for example. We've got 1,039 contributors in the Isle of Anglesey, an estimated symptomatic COVID of 5.2% there, which is surprising because it's mainly sheep. But I'm told it's quite a good place for people with second country homes, maybe living in London, escaping from other places, and that could be one reason why we get these as hotspots. And we were able to pick up these other areas in near Gwent that have been in the news about having high rates, and we're seeing rates of 7% of people symptomatic at that point in time. And these may be underestimates when we account for deprivation index, because we're basically underestimating the poorer areas of the country in terms of the prevalence. So these maps are being fed back to the government every day. I send them to the Chief Scientific Officer and his team, and their modeling team are getting these as well. So they're quite fun to play with, and you can look at your own areas here, but you can see very broadly that most of the problems are in the big cities, London, Manchester, more so Liverpool, Glasgow and Edinburgh, as you would expect. But again, there are these odd hotspots in other parts of the country. And if we, I think we go down. I can't. Oops.
While you're doing that, Tim, I mean, I guess the really importance of being able to feed this back to the government is because while we're, planning healthcare resources, like, for example, building these big hospitals like the Nightingale, which obviously is in central London, so that's a place which we know is a hotspot. But it's important that we kind of provision healthcare, or the government is able to provision healthcare where it's most needed at the right times.
Yeah, and this is we've just this is the latest map, which actually showed a reduction, about a 30% reduction in the rates of COVID across the country. Now, there's a few exceptions where things are happening. We don't quite know what's going on here in East Anglia. That might be a blip, or it might be real. And some other ones here in the Midlands. We're still seeing this hotspot here in Wales, although the general trend in the last 4 or 5 days has been downwards. And we believe that's due to the effect of the lockdown. So all our data was pretty consistent with this idea that our app has been running for 2 weeks, and for the first 4 or 5 days, everything was going up. So it looked like a lot of people had been exposed just before lockdown, and there was a lot of debate about when that lockdown should happen. And so they went into their houses and probably infected each other in your small group of houses, and so rates went up for 5 days, and then basically they've continued to drop for the next 9 days steadily. So, but there's still lots of people out there with infection. Even if the rates have dropped 30%, there's still an estimated 1.4 million people, at least, we think, who are infectious at the present time. So this was useful information which we fed to the government, which agreed with our other estimates of some of these risks, as they're getting some data from people ringing the 111 helpline, being triaged, although just a snapshot, and that's only, of course, if they have fever or persistent cough, not this range of symptoms that we think is a better indicator of the real amount of the disease in the population. And there's a few other indicators they were getting from some other surveys, but based on very small numbers. So this was helpful for the government, and it's helpful for them in saying how long this lockdown process is going to go on for, because as we've mentioned, that there's this lag phase, we think of about 2 weeks between when we're seeing symptoms and when people are admitted to hospital, and even about 3 to 4 weeks when actually people end up dying. So it's very important to have this early detection, akin to radar, system around the country, and that's why we're very proud to have actually got this together, which is, we think, is probably the UK's largest citizen science project that's ever been. And this all happened just with people working with no real resources, and everyone doing it pro bono, and people spreading the word like you guys.
That's great. Yeah, that's incredible to know the impact all of that data has on policymakers, and also helping public health services in the UK. That's really incredible. And I think you started to have people from Twins UK, the UK's largest adult twin registry and the most clinically detailed in the world, having people on Twins UK giving data on this app. Could you tell us a bit more about the involvement from Twins UK and how important that database was?
Well, I suppose that actually the whole idea actually came out of us wanting to use Twins UK as a cohort, talking to them, knowing that they're really keen to be involved in COVID research. But of course, we had to stop our usual twin visits and operations. So immediately we're like, well, what can we do with the twin cohort that's actually going to help this epidemic and understand it? So that's where the symptom tracker started, that I was putting together with Zoe, who's the company, the health data science company, which actually have been amazing in developing this app. They're working entirely pro bono to put their resources towards doing this, because of course their operations have also, like many people, slowed down because of the issues of COVID. So then we got this app ready, and at that time I think Tim felt this is really important to get it out to the general public as well. So that the twins was the part of the idea, but now of course we've got twins that have done the app, which we've linked to, and we can look at very interesting things in relation to risk for COVID. So one of the things that we're just working on a paper on right now is around looking at, well, what is the balance between nature and nurture in terms of symptoms like fever, symptoms like this loss of taste and smell? Is there a genetic component? Could that genetic component, in fact, further down the line we'll be asking, could that genetic component be one of the things that explains why different people respond so differently to this disease? So we think that the twins cohort is going to be absolutely crucial to understanding. And so we're doing not just this study, but also other studies within Twins UK to really try and get to the science and the biology underlying the disease.
Yeah, I should just mention that we've had about 3,000 twins have completed the app, and there may be more that we haven't yet linked the data on. So it's 1,500 pairs, a combination of identical twins and non-identical twins. And what we're looking at is whether the identical twin pairs are more likely to share symptoms than the non-identical twin pairs. And are indications that some of those symptoms are more shared. And the only reason for that, if we do see this increased sharing, which preliminary results suggest is true, is because the identical twins share more genes. They share all their genes, and the fraternal twins only share half their genes. So it's the perfect natural experiment, and we can then just take the difference between the two groups and estimate how much of this variability between all of us in the country as we're experiencing is actually down to something genetic, or is it something in the atmosphere, our environment, whether we smoke or our diet or these things. So it's fantastically important research that's going to change the direction of a lot of COVID research when we publish it, and we hope to get this fast-tracked and get something out within a week. So things are happening at an amazing rate, I should say, compared to the old academic speed that many of you guys listening would know about.
You said you already have 2.1 million people who downloaded it. That's incredible.
Yeah, as I said, I think this is the largest citizen science project ever been in the UK. I think there was one. There is some US project, some Earth project, I think, that someone told me about was slightly larger in the US, but I'm unaware of anything of this scale. And so, yeah, we should be embracing it. And this has all been done with no official support from any governmental or health body or even any major charities so far. So we could go much bigger if we did get all this slow-moving support.
Wow. And so you were saying that I think that we don't need to have any symptoms or to have had any symptoms. How does that help to have people who don't currently have any coronavirus symptoms or who think they never got infected?
This is a good point. So what we really want is to have a nice snapshot of the whole population. And we need to have them, at any single time point in time. And of course, hopefully at the moment, there are still more people who've not had contact with COVID. And so most people should be not complaining of symptoms. That's what we want to be able to see with the app. So we need to be able to have people who are not having symptoms logging on as well as those that have symptoms. in order to compare really what's going on in the symptomatic group versus the non-symptomatic group. So we would really encourage people to log, even if they don't have symptoms.
But the question about how it often comes up, we got asked how many people have asymptomatic disease, and unfortunately this country has been too slow in getting any population testing, so we've got no clue other than from a few surveys in other countries, and the rates vary from about 10% of people being affected are asymptomatic to up to about 50%. And we simply don't know, but it's possible that with enough data, we could predict from our population, once we get a few samples, exactly what proportion of the people who are, for example, in an area with high rates of disease would have been affected and therefore asymptomatic. So I think we'll be able to make some guesses, but to do that, we will need a lot more data and over time. And I think people have got to see this not as just something that's happening for a few weeks, but this is the start of a long campaign, probably lasting several years, with several waves of infection that we really need to understand and get to grips with. And this is why having a tool that allows us to see what's going on is going to be an invaluable long-term thing.
Just wanted to make a little point about generalizability of the population, and also symptoms in different at-risk groups. My job, my usual job, is as a geriatrician, so I'm very interested in older people and people who have multiple different medical problems that often accumulate with age. And certainly within the app data, we're seeing that there are a lot more atypical symptoms, so symptoms that are not classic of COVID, that are in people who are frailer. And that's a really important thing to get across, that not everybody will have the classic symptoms. And so the more that we can collect data from older participants, and also participants that are not necessarily in the highest socioeconomic groups, because we know that from our data, we know already that this disease is not being equal across the socioeconomic gradient. But still, we probably are underestimating how big the difference is, because we have fewer people of very low socioeconomic class who actually, as we know, may be burdened by this in many ways more, partly because they may actually still be going out and working in their livelihoods. So I guess that's another sort of message to get out there, that the more representative we can get the data to be, so that's by the more people joining from those groups, the older groups and the less well-off groups, the better our predictions will be for the population.
Yes. Yes, that's quite important to have the representation of everyone, but I guess it must be a bit difficult for people who are not quite familiar with apps. I don't know whether this can be used just with a smartphone, or do you have other possibilities for people who would not be using smartphones, for example, to use also the app?
Well, you can use an iPad, and many older people like reading from iPads, and so they can download it that way. And the company will be introducing next week, hopefully, a feature that allows you to log in for someone else. So you might have an older relative or a friend who can't use a phone but is at high risk, and you can actually do multiple entries on their behalf. We just need to sort out some of the consent things about doing that, but a lot of people have asked us about that. And eventually, once we get some time and resources, we could have a web-based version of this, although web-based versions are always clumsier and actually less easy to use and harder for people to use on a daily basis. So we think these workarounds won't completely answer the problem, because you're never going to get full coverage in elderly or very sick people. We have to accept that. But I think with enough people, we can take a sample from them and get a pretty good idea.
Which we already can do already, but I guess the models are always better. the more we have. But I guess at the point about iPads, Tim, I mean, I think it's really important to this time to get as many people as possible using sort of iPads and being able to connect with each other with technology. And so this is a real opportunity to make sure that everybody who's older or doesn't have access to apps for some other reason, to try to help them to do that, because they'll gain an awful lot more from the interactions they can have otherwise if they have that technology available to them.
Yes, exactly. And then once we get that group engaged, all they have to do is share it with 2 or 3 other people, and this app can spread faster than the virus itself. So that's the logic behind it. It's all about, and we've actually looked at the stats of the first 2 million people, and most of the direct interaction with the app has come from people sharing it rather than listening to Claire or myself talk about it on TV or in a newspaper. So again, this is the modern, very much the modern way in which messages get spread. It's very different even to just 5 years ago, what's effective media and what isn't. So it's a very different world out there, and we wouldn't be able to do this at all 5 years ago. Certainly wouldn't be able to build an app like this in 3.5 days. We wouldn't have the computers to analyze it, and we probably wouldn't have the population response to it in the same way. And so, we got a new disease that we're encountered with, but we do have suddenly new tools to fight it with that can be, got at with the same sort of speed.
Yes, that's very impressive. And you're saying that we only need to use this app on a daily basis then, or do we need to receive some kind of home testing kit, or how does that work?
Well,
we're going to be doing home. Yeah, go on, Tim.
The app is just a sort of a 1 minute click on it to just say, are you well or not? If you're not well, what symptoms do you have? Okay, so, and you should get a notification every day just to say, oh, you haven't filled in your symptom today. And it's dead easy, and everyone can do that. It doesn't automatically link to any other testing at the moment. We're not ruling that out, but I think what we'll probably do is link this. We are linking in the twins to do a subset of the twins and send them testing kits, because we already know so much about the twins that each person, they're both the best studied people in the country. They've had, we think, about £30,000 worth of medical tests per person. And so we can use all that just by linking it to their symptoms and their swab tests. And in the future, we may be able to link everyone's symptoms to getting antibody testing to see whether you can use your own symptoms and an algorithm as a sort of passport that we can validate in a subset that get the antibody testing. So in a way, in the future, we're thinking possibly that if you record really well when you get the virus, that might well be enough to be good enough to get you some form of certificate that you're likely to have been positive, depending on what it's used for and how we need it. Because people don't quite realize that a lot of the tests that are being used, the swab tests and the antibody tests, are not very accurate. And so by combining with the symptoms, we might actually do better.
Okay. Claire, did you want to add something on those tests, or I do have another question that's a bit different to that, so go ahead if you do.
Well, not really around the tests. Yeah, I mean, the tests, if Tim's right. So the tests, interestingly, if you have a sample of COVID-19 in the lab and you test it, you can get pretty good accurate results. You can get 100% results with PCR, and indeed with other tests that we've been playing with, which might be interesting, point of care tests. But if you look at it in people, the trouble is that people shed the virus only over a certain period of time, which is different for different people. And they don't necessarily shed it on the day that you actually are doing this, the swabbing, which is one of the reasons why the positivity rate for clinical samples is, actually quite variable. Some studies 60%, very few studies are greater than 75% sensitivity for an individual swab. So I guess that's one of the issues around testing, which has been plaguing the sort of rollout of it, because you can't be absolutely sure of a positive result unless a negative result rather, unless you do multiple days of testing. Especially in the presence of symptoms, which in the context of a pandemic might make you much more likely to feel that somebody is positive. Yes, so when serology comes in, though, if it does, as soon as it does, then it will be a different picture. But of course, what's not known at the moment is how long either the antibodies last for in a person with this new novel coronavirus, and secondly, how long the immunity, the actual de facto clinical immunity lasts. So those are things which are another sort of set of things which need to be understood before we've fully understood this disease.
Okay.
We've got lots of questions, I imagine, haven't we, from the audience? But
I do have a question about how we are making sure that personal data is being kept secure, because I think that's quite a worry for some people to start that kind of adventure, let's say.
yes, sure. So the app itself and the company is a data science company, so they base their whole company on keeping data secure. And so they, if you look on the website, there's a whole section on the data security, and it's been audited and checked by various external bodies. And basically, they don't release the full data to anybody, and they're kept in a secure firewall. Even us at King's only have truncated postcodes. We don't get any emails. So all we know, we have a list of symptoms, age ranges, and a very rough postcode, and that's the most people will get. The only people that do get some semi-personal data are the NHS, and people are signing up on that basis, and that's kept in an extremely secure server run not by us, not by the company, but by Health Data Research UK, which is a collaboration with SAIL and a consortium that's kept in the safest health data server in the country in Swansea. So we're very careful about privacy of data, and basically we don't want anyone's personal details. It's of no use to us, and we're not looking in that way. But people can check on the website if they're concerned.
Okay, yeah, thank you for all that information. That's always good to know how personal data is being kept secure. You mentioned that this app was a national app. I was wondering whether this kind of tracking app would also be available in different countries in the world.
Yeah. I've just been on a call with our collaborators from Harvard University in Boston, where we've already launched, I think a week ago now, Tim, the American version of the app. And what we were discussing today was how we're just tweaking some of the questions, or rather adding to some of the questions to make it in line with the NIH, the National Institute of Health over there, as well as with other groups in the UK, like the Wellcome Longitudinal Population Studies. So yes, other countries, US is doing it, and I think Tim, we've given the code to Sweden. We've also given the code and algorithms to other researchers doing projects in Africa. Many groups have been very interested, and we've been sharing as much as we can the design of the app so that it can be used by other people. Because of course, everything we're doing here is pro bono. It's all about trying to help everybody who wants to turn a light on for the coronavirus to do so in their own countries.
Great, thank you very much for all of this fascinating discussion. I think we can now open the questions to the main audience. So I think Marika is going to start with the first question.
Yep, sure. Let me just put my video back on. Can you guys hear me okay?
Yes.
Great. So the first question we have is from Mark Curtis. Has your data indicated anything regarding the risks of reactivation of the virus or reinfection?
Not yet is the answer. We need more longitudinal data. So you're not going to get that in 2 weeks yet.
Right, okay.
You'd be able to detect it, which is kind of a cool idea, that we could detect when people are having symptoms again. We won't necessarily know whether it's for definite COVID, but we will obviously, if that's put in context with other things, it may help understand that particular important issue.
Because there are some anecdotes, as people know, out there that people claim to have been infected twice with virtually the same symptoms. And we don't know how rare that is yet.
Great, thank you. Francine, did you want to ask the next question?
Yes, the next question is by Ryan Zafal. Given that a great number of symptoms have a neurological origin, loss of smell and taste, headache, does it explain a potential crossover into the brain of the virus?
Well, this is an interesting thing that I, with a number of other researchers, have been looking at in relation to older people. And also there is a potential for the neurological system to be involved in the rapid development of some acute respiratory distress syndrome. So it is a relevant question and definitely an important topic. Having said that, from clinical experience, the severe respiratory distress that's seen is generally secondary to virus itself. And I think that's fairly clear coming from Italian and Chinese data. But whether some of the symptoms are in a sense due to a neurological activation, I think is yet to be seen. The ACE2, which is ACE2, is angiotensin converting enzyme 2, which is the molecule by which the SARS-CoV-2 gets into the cells. That molecule is found in the lungs, it's found in the myocardium and in the kidneys, and to a certain extent in the brain as well. So that it is possible to conceive of the fact that the virus could get into those cells, and indeed both myocardium and kidney, renal tubules are affected in severe disease. Yeah, so hopefully that answers that question as much as we can at the moment.
Thank you.
I have a question from Alex Marley. What is the age range of the people using this app? He says, I would imagine these symptoms are skewed towards a younger patient population.
So that's right. So we have very good coverage up to the age of about 70. After the age of 70, we've got quite a sharp tail off. We do have some people in the 90s doing the app, but we do have quite a sharp tail off. But luckily, because the data size is so big, we still have quite substantial numbers of people in those older age groups. Yes, so a lot of our models now are really trying to bootstrap, use special statistical methods to try to account for these kinds of problems within the data set, so that in a sense we're simulating a data set that's more real and mapped to the general population.
But in general, we're seeing symptoms in all ages, and so it's possible to you know, there might be slight differences, but it's not like it's a completely different disease in people above, you know, above and below 30 or above and below 50. It seems there's so much variation at every age group. That's really what we're seeing.
Great, thank you.
Victoria Baines asks, do you foresee changes to how data is used in public health post-coronavirus?
Well, hopefully it's going to make a change that people will be more interested in the benefits of sharing health data widely rather than worrying about privacy issues. So I think my hope is that it will actually enhance us having common systems, having a common NHS site that all your data's there, and I think most people are actually pretty relaxed about it, and and it should be the objective, like in the NHS at the moment, is we're hampered on our research because of all these privacy issues. We could do so much more discoveries and everything else if people just said, well, 99% of the time, it's going to be wonderful for scientific research. We just have to take a potential small hit occasionally, that there might be some loss of privacy, but in the balance is much more in favor of doing good for the community. So that's my personal hope. And I think things are changing. We know the government said that Hancock tweeted that GPRD should be relaxed where there's an urgent need to find out more about this virus. And I think that's an indication that we shouldn't get so stuck up in these issues when the relative balance against the population's health is very much greater. So that sharing data is one thing that should hopefully come out, some good thing that come out of this.
Yeah. So it's very interesting. Obviously, the reason why this is an issue is because of health data is very personal, and so does, of course, need to be treated with utmost sort of safety. But we do have the safety mechanisms in place. And for example, the UK SERP, the Secure Research Platform that Tim was talking about in Swansea, is one very good example. But actually, on the day that the lockdown happened, I think, the day before, I was asked to go and speak to some students in a school in a sort of big seminar around data and health. And I was saying that actually we're really on the edge of an absolute revolution in terms of using data in health. And we're behind the curve because the industry have been using it for some time. But actually using big data is really, really good at predicting health problems. And it's much better than doctors like me or Tim. And we really should be using that much more in our medicine. And maybe you're right that coronavirus is going to be an extra tip, an extra sort of thing that's going to help bring that into the health sphere, where it's been a bit delayed, to be honest. And that will be definitely for the public benefit.
Thank you. I've got one on, this is an interesting one. Are you finding the media coverage of COVID-19 a help or a hindrance?
I think we're hearing too much. My personal view, I mean, I think for our research, it's neither here nor there. I mean, we've got a lot of good coverage ourselves, so I think the media are interested in our story, but we're always drowned out by death counts. And I think our obsession with having death as the only outcome that matters is become a bit of a national obsession, and people are looking at the scoreboard and seeing it that way. They're not talking about all the other consequences and the other, I'd like to see a wider balance of all the cancer cases that could, might not be cured now that would otherwise. And I think there's a danger of us getting just so obsessed with this that we lose the focus, because I know many patients with disease, really nasty disease that we can do something about, are being turned away from hospital. And I think this this fear about infection, when most people are getting it mildly, is actually killing other parts of our society. So I'd like to see a broader discussion rather than just, you know, another 200 extra deaths today. And many of these, you know, in other years wouldn't be reported at all, because, you know, about 500,000 people die a year. We don't actually have a death count every day on those causes. So it's a bit morbid about what we're doing. So we need to take a wider picture is what I think. That's very much my personal view. I don't know what Claire thinks.
Well, I think I would echo the fact that I just want to bring in another study that we're doing, that we're just about to launch, which is on the potentially much wider and more deep repercussions of this huge social change of social isolation, and the really big impact on families, on individuals' economic health, on jobs, on just simply sort of, you know, health, things like exercise, but also the huge changes that might be for the positive, like new working from home. Here's me, you know, we're all working from home here. We've got a new experience there. The changes in environment that are happening now because of the difference in human activity. So all these really big questions, this is a really, these are really important to study, because what we don't know is what are the longer term repercussions of all of these things on our health and well-being, you know, now and for time to come. So we're really pleased to be part of the Wellcome Longitudinal Studies, population studies in the UK, and we're going to be asking our twins, we've already been talking to our volunteers about exactly how we're trying to map this experience more broadly. And we're champing ahead so that next week the questionnaire will be going out to everybody now, and then we'll be looking later in a couple of months when the epidemic is on its way out, and then further on to see what kind of repercussions are happening and how different people might be more resilient, and what the resilience factors are.
Okay, I guess, could you share with us the hope you think that this app can give us for the future?
Okay, so the long-term view. Well, as I said, I think this isn't something that's going to be over, you know, by June. I think this app is a totally new tool for the NHS. That if we can just get that extra bit of support, and we've just heard, just while I've been on this call, I heard that the Welsh government are now supporting the app and will allow us to put NHS Wales as an endorsement on it, and hopefully that will trigger the other devolved governments to do the same. If it's going to be here to stay, I think this is very much, we need to start having both this tool as a long-term device to see when the next epidemic's going to hit, because these will hit in waves. So we need to see this as in cycles, because this lockdown is going to continue for another probably 2 to 5 weeks, and then there'll be a gradual easing, and then of course the numbers will start to go up again, and then it will disappear, and then there'll be a period of time and there'll be another outbreak in susceptible people. And so having these devices in place is going to allow us to react much faster to what's going on and target certain areas with rapid testing, etc. And I think the use of the app, as I said, I think combined with antibody testing could be the way we could all get out of lockdown. So by carefully documenting our symptoms plus an antibody test, that combination could be the absolute one that gives you your freedom passport, if you like, to go around the world and live a stress-free life. So,
well, potentially that could be hugely important, Tim, because if it can help accelerate the coming out of lockdown, then of course the economic and social effects of lockdown will be minimized. Yeah.
I think there's an altruistic side to doing this this app, which is for the good of your community and your local hospital. There might also be a personal side to it that should you have really well documented symptoms and timings and everything, that could be really useful for you in the future as you may need to document whether you've had the infection or antibodies in terms of visiting anywhere or hospitals or going abroad on holiday or on your cruise ship. Who knows what the future will hold. But I think what we've seen is these apps like ours are here to stay. They're part of our lives. And I think that's a really exciting bit of this rather grim period we're in. And the fact that all you citizen scientists can make all this happen just by yourselves without actually any government action, just a few people getting this spark going and you sharing it with your friends who then share it, shows that what the power of the community. So to me, that's been a really emotional experience, and it's been a fantastic 2 weeks to see it happen. So I want to thank all of you out there who've done this and spread the word, and want you to keep doing it because you're doing a fantastic job.
Thank you, Tim. And just to kind of follow on from that, we've had quite a few questions about how we can help. How can we help you get some more establishment and financial support for this project? One suggestion has been to get the app promoted on TV, for example, to increase the numbers of people submitting their symptoms. Can you just tell us how can the public help?
So apart from spreading the app around, because that's the best way to get it noticed, finding out some influencers who can advertise and give some pro bono advertising, influencing your charity that can send it to all their members. This can include medical charities for particularly the elderly or people who are at risk. We're still not getting good traction there. If someone will pay for some free adverts, some benefactors, that can do. And sending an email to Matt Hancock to say, hey, this is a good news story. There's over 2 million people have done this off their own backs. Get behind it and get it up to 10, 20 million.
Great, thank you. Claire, did you have anything to add before I wrap up?
No, but I just wanted to echo what Tim's saying, that really this project's just taken off because of the great support from the public. And I think that's because everybody around knows that really the only way to beat this is to know where it is. And the only way to do that is either by testing or by tracking symptoms. And so I think that's really the key. I just want to say thank you to everybody who's done this, because I think it really will make a difference.
Fantastic, thank you so much. So that brings us to the end of today's webinar. Don't forget you can learn more about the app and how it works on the website. We'll share those links with you afterwards. We'd like to close today with a huge thank you to Tim and Claire, who've kindly given their time today, despite their busy schedules, to share their work with us. I hope you've all found this webinar helpful, and will download the app if you haven't done so already. If you have any questions about anything shared today, please do not hesitate to get in touch with the Alumni office. You can email us at forever@kcl.ac.uk or through our social media channels. You will also be able to find this and any past webinars on the KCL Alumni YouTube channel. Should be up there by tomorrow. And if you would like to share this webinar with your networks, please don't forget to use #ForeverKings. Finally, I wanted to mention one of the many ways you can support Kings during this time. A huge thank you to all those who've already contributed to the King's COVID-19 Response Fund. Any donations will support work that tackles the crisis, researching life-saving treatments, mental health support for our incredible NHS staff, a global response to helping developing countries, and also helping King students facing financial hardship as a result of the epidemic. If you would like to make a contribution, please follow the link. I think it'll be posted in the chat box and in the email afterwards. Finally, please look out for future webinars on our alumni events page. There's an alumni versus students pub quiz on April 30th, and we'll be speaking to Tim Spector again on the 21st of May, when he'll be sharing details of his new book. Once again, a huge thank you to our panelists for joining us today, and thank you all for listening and submitting your questions.